Thank you for joining us today for our webinar, Milk Allergy, How to Manage It and What to Consider from a Dietary Perspective. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speakers today are Dr. Karina Venter and dietitian nutritionist Marian Groch. Before we get started, I want to note a few items. Please note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions upon registration. There are some common questions and we will tackle those in today's session. If you have additional questions during the session, please submit them in the chat or question box throughout the webinar and we'll try to get to as many of them as we can. And lastly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. So first, a little background on today's session. Today's session is all about milk allergy. As part of our Back to School campaign, we are aiming to raise community awareness of allergens other than peanut and offer programming specific to other allergens. Many of you listening in today may relate to the lack of broad recognition of milk as an allergen and misunderstandings that exist between lactose intolerance and milk allergy. Additionally, milk is indeed one of the more complicated presentations of food allergy, as there are many different types under that umbrella label, specific types in infancy to persistent IgE-mediated milk allergy in adulthood, or what some might refer to as an anaphylactic allergy. Regardless of the type, there are dietary questions that arise when someone is managing this allergy. So today's session will help to clarify the broad types of milk allergy and the terminology to describe it, how they are differentiated, and get into the nutritional aspects of managing it. To accomplish this, we are delighted to have two experts join us. Marian Groch is a dietitian nutritionist and a director of nutrition services at the Jaffe Food Allergy Institute and associate professor at the Icahn School of Medicine at Mount Sinai in New York. She serves on the medical advisory board of the International Association for Food, Protein, and Enterocolitis, is a past chair of the International Network of Dietitians and Nutritionists in Allergy, and plays active roles in both the American Academy and the European Academy of Allergy and Clinical Immunology. Dr. Karina Venter is an allergy specialist dietitian and associate professor in pediatric allergy and immunology at the Children's Hospital Colorado and the University of Colorado. She is past chair of the International Network of Dietitians and Nutritionists in Allergy and is a member of the American Academy, the American College of Allergy, Asthma, and Immunology, the European Academy, and also the British Society of Allergy and Clinical Immunology. Dr. Venter has also been involved in allergy prevention guidelines in the US and in Europe. So thank you to both of you for taking time out of your busy schedules to be with us here today and to help us learn from your expertise on this subject. So over to you.
Thank you so much, Jennifer, for the introduction. I hope you're seeing my correct screen. I'm very excited to be here today, and we're excited to talk to you about how to manage cow's milk allergy. So I think the first thing we should talk about is the prevalence of cow's milk allergy in Canada. And I think it was interesting that Jennifer said that cow's milk allergy is misunderstood, because 1% of the population actually is thought to have cow's milk allergy. And studies suggest that around 4% of infants are allergic to milk. But for many of the infants, the allergy will resolve with time. And that's why we see fewer adults with cow's milk allergy. So we're hoping that for all of you who may be living with cow's milk allergy at the time. So I think before we start to talk about cow's milk allergy management, let's get on the same page regarding what is food allergy. So this definition comes from our guidelines for the diagnosis and management of food allergy. And the definition is an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. So a food allergy or the food allergy symptoms are triggered by the immune system. Now, there are many different types of adverse reactions to foods. On the left-hand side here, you'll see there are non-immune mediated food reactions, and these are our food intolerances. So an enzymatic reaction would be lactose intolerance is a great example of that. We're missing the lactase enzyme, or we have low levels of the lactase enzyme, and then it's difficult for us to digest the milk because we don't have that enzyme that breaks it down. This is a food intolerance or a lactose intolerance. We can have a pharmacologic effect. A good example of that is how coffee can make some people jittery. It's not a food allergy, it's an adverse reaction to a food that is not immune mediated. And then of course we can have toxic reactions or food poisoning. And again, this is not a food allergy. So we're not going to be talking about food intolerances today. Today, we're going to be talking about immune-mediated adverse reactions to foods or food allergy. And we can further divide food allergy into those that are IgE-mediated and those that are non-IgE-mediated. So IgE-mediated allergy is what people generally think of when they think of food allergy. Symptoms are typically rapid in onset, occurring within minutes and up to 2 hours after ingestion. And with IgE-mediated allergies, multiple organ systems can be impacted, such as the skin, the lungs and breathing, the gastrointestinal tract, and even the cardiovascular system in a severe reaction when blood pressure can drop. IgE-mediated allergy can also present as anaphylaxis, and this is where multiple organ systems are impacted. So this is in contrast to non-IgE-mediated allergies, and the most common of which is food protein-induced allergic procticulitis. I know that's a mouthful. It's commonly called cow's milk protein allergy, and this generally presents with blood in the stool in a very young infant. So this is understandably an alarming symptom for parents, but it does not present the risk of anaphylaxis, and children are usually thriving and doing well other than this symptom of blood or mucus in the stool. This generally resolves by 1 year of age. So we're going to be talking a little bit about non-IgE mediated allergies because some of your questions that you submitted were related to this cow's milk protein allergy. There are other IgE-mediated food allergies such as FPIES and EOE, and we're not going to be covering those today because there are upcoming webinars that are going to be covering those in detail. So today we're going to be talking about IgE-mediated allergies and then these sort of mild and moderate types of non-IgE-mediated allergy. So I'm going to hand over to Karina. Dr. Venter, she's going to be talking to you about diagnosis.
Good morning or good afternoon, and thank you also for the invitation to present here today. So the next few slides, I'll be discussing diagnosis of cow's milk allergy. I may say this again, but I do want to say at the start, there are many nuances to diagnosis of cow's milk allergy and food allergy. So your allergist might have taken a slightly different approach to what I am suggesting, but this is sort of like the overall big view of how we diagnose cow's milk allergy. So it's important to start with questions. Now we're heavily debating whether a family history of atopic disease, so family history of asthma, eczema, food allergies, not necessarily just cow's milk allergy, and allergic rhinitis may predispose the child or put the child at a higher risk of cow's milk allergy. But Marion and I sit on many guideline panels across the world, and having just had the discussion about this at European level, I think the general feeling still is that there may be some lack of direct association seen, but this is always a very good question to ask when we take an allergy-focused history. Then in terms of cow's milk, we need to understand this infant now presenting with symptoms. Has the infant been exclusively breastfed up till this point? Has the infant been mixed fed? So have you introduced formula, and did the symptoms occur when the formula was introduced? Has the child always been on an infant formula? And was there a lot of changes? My own data from the Isle of Wight, now about 20 years old, actually showed that by the time we get the children with the cow's milk protein allergy or proctocolitis, um, where often, or the children with the milder to moderate cow's milk allergy, where the colic isn't improving or the reflux is not improving, at which point we call it reflux disease, there's already been a change of about 5 or 6 different formulas. So change in formula is also a good indicator that there may be some issues with milk tolerance. We ask about presenting symptoms. I always say to the doctors, if you don't tell me which mechanism of cow's milk allergy I'm dealing with, I really struggle to shape my avoidance advice. And so, as Marian nicely explained already, we have the immediate type cow's milk allergy. So the children may present with hives or angioedema, which is swelling of the lips and the eyes, immediately after consuming infant formula, usually when it's introduced for the first time alongside breast milk, or if this has been a breastfed infant, usually the first time or perhaps the second time when a yogurt is being introduced. Then we get the children with the cow's milk protein allergy or the proctocolitis, where they present with blood in the stool, but we actually have a very happy, thriving baby. And then we may have children, like I've already explained, with very troublesome reflux, where we may want to consider taking milk out of the diet. There's also the food protein-induced enterocolitis or FPIES and eosinophilic esophagitis. I can't help to mention it, but as Marian said, you have separate webinars on these particular 2 presentations of cow's milk allergies. In terms of cow's milk in particular, it's important to ask whether there's any feeding issues. Babies who back arch and scream the minute you bring the bottle close to their mouth, that's normally a very good indicator or red flag that we may be dealing with a cow's milk allergy. Babies with poor growth, so despite the fact that they may drink milk, they just keep dropping off their percentiles, or they're refusing milk. And I see moms that say it's a 24-hour a day job to get 6 ounces of formula into this child, because we can get half an ounce at a push in over a 2-hour period. So, and then we see poor growth as well. And whether there's been any changes in the diet, often children, who may have reflux or reflux disease caused by cow's milk allergy, they may also start eating other foods just because they feel generally unwell. And then it's important to ask, have you tried some acid suppressing drugs, or you might have tried some colic drops? Data from Australia and United Kingdom and Europe indicate that about 30% of infants with colic who does not improve on normal medical treatment may have cow's milk allergy. That's perhaps another subject that we're also debating. But it's important to ask, what medication have you used and did it work? But if you suspect IgE-mediated food allergy, so this is the immediate type food allergy, like I said, with hives, um, you know, um, angioedema, the swelling of the face. In some cases, we may see that, especially in babies, they literally turn red top to toe. I've done many food challenges in my life with very young infants, and you don't see this flushing head to toe as you see in babies in any older ages. But that is normally also a very good sign that we're dealing with IgE-mediated allergy. They may also start wheezing, and we don't often see anaphylaxis in young infants, but when there's 2 or more some systems involved, like we have wheezing and very severe skin symptoms, some people and some countries may refer to that as anaphylaxis, or at least very severe symptoms as well. We can then perform tests to confirm the suspicion of IgE-mediated allergy. You may ask or wonder, why does the one doctor use skin prick test and another one use specific IgE test? There's really no rule whether we should be doing one of the 2 or whether both should be used. Many allergists like to do a skin prick test at the point of diagnosis because we have the results immediately available, but then follow that up with specific IgE test, because specific IgE is in particular very helpful to help monitor tolerance over time as the levels come down. Having said this, this is the world of food allergy. Anything is possible. And some children actually develop tolerance to milk without the specific IgE levels going down, although it is unlikely. We try not to test for foods that's tolerated. So if your child's already tolerating egg or peanut, it's not a really good idea to start testing for any allergen ever created, because we will get false positives. And what I mean with a false positive is that we may get a positive skin prick test or specific IgE, the blood test, to egg or peanut, while the child is happily eating the food and not having any reactions. And as I've already referred to, panel testing is not advised, so we shouldn't really be testing for 20 foods just to make sure there's no chance of a child reacting, because that delay introduction of food. Then once we have a very good inclination that we're dealing with a cow's milk allergy, and in terms of IgE mediated cow's milk allergy, we have the test to confirm that. We can then take food out of the diet, and then we can follow it up with a food challenge or a reintroduction in terms of non-IgE mediated cow's milk allergy. I do want to say that in clinical practice, if we have very clear symptoms following consumption of something containing cow's milk with a very supportive IgE or skin prick test, most of the time we will not bring the child back for a food challenge, because those two bits of information coupled with years of expertise by an allergist and training, they are totally in a position to make a clear diagnosis without necessarily having to bring the child in for a challenge. So if we go to the next slide, and then this slide really refers more to the non-IgE mediated forms of cow's milk allergy. So this is part of the DRACMA guidelines, or the World Allergy Organization guidelines on cow's milk allergy, of which I'm one of the members. And Marian has been involved in many of the papers we've written. So if we suspect a delayed type or a non-IgE mediated cow's milk allergy, we eliminate the food for 2 to 4 weeks while we monitor the symptoms. If you then go down to the diamond shape, you have to ask yourself, after 2 to 4 weeks, did the symptoms resolve? If we then go to the yellow box that says no, so you take milk out of the diet and the child's not getting better, the child does not have a cow's milk allergy, and we can reintroduce the food. If we go to the green box and the child has improved on taking cow's milk allergy, the most important thing I want you to remember today in terms of non-IgE mediated cow's milk allergy, we do not have a diagnosis at that point. We took milk out, baby got better, but in 50% of cases, babies just get better. And that's not necessarily anything to do with cow's milk allergy. So we have to reintroduce cow's milk at home. And if the symptoms recur, then yes, we've confirmed the child has a cow's milk allergy. So the blood came back in the stools, or the reflux has recurred, or perhaps the colic is worse again, or some maldigestion. We can talk about this milder forms of cow's milk allergy forever. But if the symptoms did not occur, then once again, it's not cow's milk allergy. And parents often ask me, why does it happen? Babies grow up, they get better at digesting food, at tolerating food, and sometimes just taking the food out for 2 to 4 weeks, and then reintroducing it, get rid of the symptoms without necessarily being able to link it to cow's milk allergy. So avoidance followed by reintroduction, very, very important for a clear diagnosis in these delayed types of cow's milk allergy. So we will then move on to dietary management. Thank you, Marian.
Thanks so much, Karina. Yeah, so dietary management, our goals are obviously to prevent those food allergic reactions, but we also want to maintain appropriate nutrition for growth and development. So as a dietitian, my focus is always teaching families how to avoid the food effectively, meaning avoiding it properly without over avoidance, and then also focusing on the nutritional adequacy of the diet. Here are our national and international labeling laws, and you can see Canada is listed here. And what we see here are the priority allergens that are declared as the major allergens in each country. And milk is a priority allergen across the board because milk allergy is so common. And what that means is that milk must be listed in the product label, either in the ingredient list or in a contain statement below the ingredient list, using its common name, milk. So you don't have to look for these vague words like casein or whey. You're only looking for the word milk in these food product labels. Additionally, things like front of package labeling is not regulated, so please don't use terms like dairy-free or vegan to sort of help guide you to those products. Always turn the product over and look at the ingredient list and the contain statement. I did want to discuss avoidance. I don't want to discuss avoidance at length, but I wanted to point out this novel product because it highlights that labeling reading issue. This is an animal-free milk. It's made by a novel process called precision fermentation, and it produces milk protein without cows. So it uses a DNA sequence of cow's milk protein that's inserted into a yeast, and then they grow the yeast. And the protein that is made is bioidentical to cow's milk, and it will trigger a reaction. So in the US, it's required to label this as milk. So you always have to read the ingredient list or the contain statement, and then you won't be tripped up by an animal-free or a vegan front of package labeling. So we talk about nutrition because we know that children with cow's milk allergy are at increased risk of inadequate nutrient intake and poor growth. And this was a study that we conducted in 2019. We enrolled children from 12 centers worldwide. We enrolled 430 children. And of this population of children with food allergy, so they weren't specifically cow's milk allergy, but they were food allergic children. 8% were overweight. Now, that is somewhat of good news because the US population, 33% of children are overweight. So we do see less overweight in the population of children with food allergies, but we also had 6% that were underweight, which is actually more than what we see in the general population, and 9% who were stunted, meaning shorter than we would have expected them to be. And that is compared to 2% of the population. So stunting is actually a bigger problem than underweight in the population of children with food allergy. So we really want to make sure that we are addressing their nutritional needs appropriate and making sure that we're substituting for the nutrients that have been lost to the elimination diet. So before we talk about nutrition for children with cow's milk allergy, we have to understand a little bit about nutrition for healthy term infants. So this is the Canadian recommendations for children 6 to 24 months of age. And for an older infant or child who is not breastfed or receiving breast milk, they recommend commercial infant formula until 9 to 12 months of age. And then pasteurized, homogenized cow's milk, whole cow's milk, can be introduced after that time. Skim milk is never appropriate in the first 2 years of life. But these guidelines also say that soy, rice, and other plant-based beverages, whether or not they are fortified, are inappropriate alternatives to cow's milk in the first 2 years of life. So that's interesting. And as a parent of a child with cow's milk allergy, you're probably wondering, well, what am I supposed to feed them? If we look again at the DRACHMA guidelines, the guidelines that Karina has already mentioned, we see a similar recommendation. They recommend a cow's milk substitute of adequate nutritional value until 2 years of age to meet nutritional requirements. And that will be either human milk or a substitute formula. So even though for the general pediatric population, you can transition to cow's milk around 9 to 12 months of age, in children with cow's milk allergy, we want you to keep them on that substitute formula or human milk until they're about 2 years of age. The Galen Task Force also suggests that for those children who are breastfeeding, the mothers may not need to have an elimination diet. So in rare cases, it might be considered. So I'll tell you when it's considered. It's considered most commonly in children who have that proctocolitis or cow's milk protein allergy. As a matter of fact, about 50% of infants who present with cow's milk protein allergy, that bloody stool, are exclusively breastfed. So we do know that children who have cow's milk protein allergy are more likely to need a cow's milk elimination diet from the mother who is breastfeeding them. It's rare to see a child with IgE-mediated allergies need a maternal elimination so that that breast milk doesn't have any immunologically active cow's milk proteins, but it does happen. So when we say it's rare to be needed, it doesn't mean that if your child needs it, that you're wrong. Sometimes these things are needed. And I know one of our physicians always says to us, in food allergy, we never say never and we never say always. But in general, we're saying it's more common not to have to eliminate those foods from the breastfeeding mother's diet. And of course, we don't want to burden a mother who is trying to breastfeed their child unnecessarily. In terms of substitute formula choices, we have two types of hypoallergenic formulas. We have extensively hydrolyzed formulas. These are made from cow's milk proteins that are broken down so that the peptides are very small and not recognized by the immune system. And then for infants who don't tolerate those, we can go on to an amino acid-based formula. And these have individual amino acids. They're peptide-free, and they are tolerated by children who have all types of cow's milk allergy. Soy formula is another option for a substitute formula. We generally recommend that after 6 months of age. But remember that soy formula is not typically used for those children with non-IgE mediated cow's milk allergy because there's a greater risk of co-reactivity between cow's milk and soy in non-IgE mediated food allergy. And now I'm going to repeat again what I've said and what Karina has said. It's very important for us to know what type of cow's milk allergy we're dealing with, because when we're managing that patient, we will have different recommendations based on whether they have an IgE-mediated allergy or a non-IgE-mediated allergy, or even the type of non-IgE-mediated allergy. And then those substitute formulas that are not appropriate for cow's milk allergy are partially hydrolyzed formulas. These are not considered hypoallergenic. And European formulas that are labeled HA. Now, these formulas have not been tested to show that they are tolerated by 90% of children with cow's milk allergy at the 95% confidence interval. That is the definition of an extensive of a hypoallergenic formula. Some of them may be within that range, so they may be tolerated, but others are not. So we have to be very careful about that. So when is it that we can transition to a plant-based beverage? So let's take a look at some of these. What you're seeing here is cow's milk protein, and I'm sorry, it says 16 ounces here. It should say 8 ounces above. So for 8 ounces of cow's milk would be 150 calories. And then you start to see the caloric content of 8 ounces of cow's milk actually diminish. And when you cut down to the bottom here, almond milk is very low in calories. It's also very low in protein and very low in fat. And we know that young toddlers require a lot of protein and fat from their beverage because about 30% of their calories come from cow's milk or cow's milk substitutes. So if we're starting to give them almond milk, we're going to see a low protein and low fat and not having enough actual nutrients in there. Rice milk is another issue, low protein, low fat. Oat milk starts to get a little bit better, but still very low. I mean, this is less than a 2% milk. Soy milk has comparable protein and a little bit lower in fat, and pea protein milk also a little bit lower in fat. And we can make up the fat a little bit more easily than we can make up the protein. The calcium and vitamin D fortification is very brand specific. So you really have to read that label to make sure you're getting one that is brand specific. So you can see why some of these would be really inappropriate for a child between 1 and 2 years of age. And our North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN guidelines say where plant-based milk alternatives are used as the primary milk source in older children, clinicians must consider a carefully planned diet. So if you are working with a dietitian, or if you are a dietitian working with families, you may be able to transition a child earlier than 2, but the child will have to meet certain feeding goals prior to transitioning. So you can transition to a milk substitute when the child is at least a year of age, and they have to be able to eat a varied solid food diet with a variety of foods from each food group. They should be getting at least 2/3 of their calories from that varied solid food diet. They need to eat age-appropriate textures. So if you have a 1-year-old or a 14-month-old or an 18-month-old who is still eating pureed foods, once they transition over to the family table, you may lose a lot of that variety because accepting a pureed carrot is not the same as accepting a whole carrot, and they may refuse some of those foods. The child must be able to get enough protein and fat and micronutrients in the diet from the solid foods and the available milk substitute, depending on what foods they're allergic to and what they're tolerating. And lastly, they should be consuming no more than 14 to 16 ounces of milk substitute per day. And this includes breast milk, formula, and other dairy substitutes like yogurt. So we can actually assess the diet and transition them earlier. But if you're not working with a dietitian, you should probably stay on that breast milk or a substitute formula until about 2 years of age. Milk is an important food group throughout the life cycle, so we should think about replacing the nutrition lost to the elimination diet at all ages. And you see that calcium and phosphorus and magnesium and vitamin D are important through the life cycle. For young children, we also have to think about calories and protein and some other micronutrients that might not be supplied in the diet. For older adults, there are actually greater needs for vitamin D intake than the rest of the age groups. So we have to think about how are we going to substitute these moving forward. Calcium and vitamin D needs are listed here per age group. And you can see that children, the teenagers especially, need a lot more calcium than in other age groups because this is a time of rapid bone growth and also building the bone density. So the best sources of dairy are still, best sources of calcium and vitamin D are still dairy products, but appropriate use of unsweetened, fortified plant-based beverages also provide a good amount of calcium and vitamin D. Other dietary sources are listed below here, like some fish with bones. Many tofu varieties are calcium set, and they have a good source of calcium, and some of those dark green leafy vegetables as well. But when you start to look at some of these, for instance, let's take a look at spinach down here. You know, half a cup of cooked spinach has 123 milligrams of calcium. And if a child needs about 1,000 milligrams, that's an awful lot of spinach they'd have to eat. So you can see that either a supplement or a plant-based beverage for those older children that provides adequate nutrition and is fortified would be a better option. One thing that I want to point out is that calcium fortified juices can have a lot of calcium in them, but trying to meet calcium needs via calcium fortified juice is not nutritionally viable because you'd have to drink 2 to 3 full glasses of this in order to get the 1,000 milligrams that is required for most of those children and even adults. And that amount of juice is not recommended at any age group. So just be aware of that. And lastly, you might be thinking, how strict do I need to avoid? Can my child eat baked milk ingredients? Now, baked milk is something that we typically use in children with IgE-mediated food allergies after they have had an oral food challenge under supervision by their doctor to baked milk. So this is something that we do only when it is advised by the doctor. You might say, well, my child eats cookies from the store that have milk in them. Does that mean they tolerate baked milk? So if you look at many of the ingredient lists in products from the grocery store, what you'll see is that they have very little milk. So here we see butter is a second ingredient, but butter has a very small amount of milk protein. And then we see a milk ingredient in the area that says contains less than 2% of the following. So this is a product that your child may be tolerating, but it has a very small amount of baked milk in it. And I don't know what would happen if they had a much larger amount of baked milk. So this is why we use a standardized recipe. And when you have an oral food challenge with your physician, if you use a standardized recipe, then We know how much baked ingredient you've tolerated. Then we can provide you with guidance on home feeding of other food items. So our published recipe, and it's one that is used all over, really. I mean, many people use this recipe. It's published here in this open access paper. It uses no more than 1/6 cup of milk per serving. And this, so it's basically a cup of milk in a recipe that yields 6 servings. And we developed this recipe with high amount of milk protein in it so that we could give you guidance. If you tolerate this, we know that there are many other things that you can tolerate. So if you're interested in baked milk, please talk to your doctor about it. Your doctor will know whether your child or you, or if your patient, if you're talking about a patient, will maybe be ready to have a supervised baked milk challenge. It's not something we ever recommend that you do at home. I'm going to pass over to Karina. She's going to talk to you a little bit more about strict avoidance.
Thank you, Marian. Yeah, so Marian's discussion of food avoidance has now nicely led onto this next slide, where is strict avoidance of the food allergen necessary for everyone? And, you know, for years sitting on all these guideline panels, I've been saying that, you know, we have to move away from using the word strict avoidance, because really it is individualized avoidance that we're after. And so I was very pleased when, with this latest Galen guidelines coming out of Europe, we acknowledge that, you know, the Galen task force suggests that people with a documented food allergy avoid the offending food unless individual circumstances and risk allow for some consumption, where clearly baked milk consumption is a very good example of why we need to be individualizing advice. That also brings us to the milk ladder. And so we published the first milk ladder in 2013 in the United Kingdom. And the reason for the development of the milk ladder was that everybody read the data from Mount Sinai Hospital and the baked milk work Marian was referring to, and then wanted to play around with the muffin and wanted to know, you know, where does chocolate fit into all of this, and where does yogurt fit into all of this, and where does malted milk biscuits, which is a cookie we have in England, or the Garibaldi or digestive biscuits, step 2 on the third 12-step ladder, fit into all of this. And I got a group of dietitians together in the UK, and we phoned or called all the companies to get information. We looked at recipes, and we then designed this milk ladder for non-IgE mediated cow's milk allergy. So these are really the babies with the reflux, the babies with the proctocolitis or the blood in the stool, or some other milder and perhaps vaguer forms of cow's milk allergy, which would not pose a risk of developing anaphylaxis. And we published the paper, but and this ladder, the 2 ladders you can see here on the screen now, has been downloaded almost 1 million times worldwide. But when we got to about 500,000 downloads, we looked at the statistics, and we realized that this milk ladder was being used all over the world. And many of the foods were not really appropriate for countries such as Mexico or even Australia. And we then developed the 6-step IMAP milk ladder, which was much more focused on foods that's eaten on an international level. I want to make a point that each one of these steps in the ladder does come with the recipes, and I feel very strongly that we need to standardize the ladders as much as possible so that we know how long the cooking temperature was, what was the temperature of heating, and what at least is the calculated milk protein. And as much as we publish these ladders for non-IgE mediated food allergies without the anaphylaxis risk, and I still felt it need to be standardized, as we're now learning more and more that the milk ladder is used very successfully by skillful allergists in IgE mediated food allergy, this standardization becomes even more important. So if we go to the next one. So I was then asked with a group of experts to talk about or to write about standards for ladders, and this is what we suggested. And Dr. Doug Mack, who many of you may know, was the lead author with me on this paper. We say that information on dose of the allergenic food is important. It should be calculated. If you can measure the protein content, then even better. I'll show you 2 ladders subsequently where we did measure the protein content. Time and temperature of heating should be specified. Simplicity is important. I personally prefer a ladder with just 1 food per step because I know what the protein content is and I know all about the cooking. I think when we start putting different foods in one step, it becomes a little bit more complex, but that is perhaps just my personal view, and it doesn't necessarily mean that it is incorrect to have ladders with different foods in one step. The possible effect of the heat matrix should be considered. So we are doing a lot of work as I'm speaking on testing the allergenicity of different kinds of foods with a wheat matrix, so something like a bread with wheat in versus a rice pudding without wheat in. And to some extent, we see that wheat does affect the allergenicity, but not as much as we thought. And it's really the timing and the temperature of heating and also the fat content that's most important, and then testing the level of allergenic proteins. So let's keep going. I talked about that. Nutritional aspects. So when I published the first ladder, I had mothers contacting me on Instagram and all over Twitter saying, Karina, you're a dietitian. This ladder is loaded with sugar, which was one of the other reasons we developed the 6-step ladder where we've got all the sugar. Well, we haven't got added sugar in any of the recipes, but we definitely wanted to make sure that we stay underneath the WHO recommendations of acceptable levels of sugar in a child's diet. It needs to be taste and texture acceptance. I think we can still improve current ladders for young babies where they're not ready to eat a muffin yet, but I often just mash it up with their milk-free formula and sort of like in a slush, and they may eat that. We have a lot more culturally appropriate ladders, which I'll show you. Practical recipes. The first ladder with the lasagna, I know that that's not one of Marian's most favorite recipes because it's complex. There's different types of milk in it. And quite frankly, we all know to really bake a lasagna from beginning to end is about a 2 hours job. So we've tried to make the recipes much more practical and simple in subsequent ladders and clearly identify the protein content. I'm not going to talk too much about the medical aspects today. This is really up to your allergist to decide which patients can undergo ladders outside of the clinical setting. Allergists, that's their job. They weigh up safety and risk factors. So some of you may have to come into hospital or clinic for updosing. In some cases, your allergist may be happy to do the updosing or step to the next step of the ladder at home. Number of steps or days per step is very, very individual. There's no way of giving clear advice on that. Whether you're able to carry your epinephrine and can administer it and you're not living in a remote area may also help the allergist decide whether your step up is going to happen under supervision or at home. But clearly, in the non-IgE food allergies, we don't really have to be concerned about these issues because we're not dealing with anaphylactic risk. And then it's important that we should provide written instructions, which we do have with the IMAP ladder, because parents in the United Kingdom clearly ask for this. Go to the next one. This is just Mediterranean milk ladder. If you put that reference in Google, you can actually download that ladder for free. I cheated you a little bit by just showing you that we try to mimic the IMAP ladder into Mediterranean foods, but the Mediterranean foods we included are Mediterranean lentil burgers. We have bread with olive oil and sun-dried tomato. So really, we actually have a rice pudding recipe in there as well. So if you would like to use a Mediterranean ladder opposed to what else is available, please go on and have a look. But please don't download it and use it without physician instruction. Definitely not for IgE-mediated food allergy, but also in case of non-IgE food allergy. I also worked with a group of gastroenterologists mainly and a dietitian in India to develop an Indian milk ladder. Once again, if you click on the link on the slide, it is free to download. This took a lot of work. It took us about 3 years to get this ladder published. We did actually also make, just as with the Mediterranean milk ladder, we did test the milk protein content in laboratory settings. But the biggest job here was to reduce the sugar content to as much as humanly possible and still make it palatable. But I would say that in all these cases, we've cut the sugar content by at least 75%, and only one of the recipes now have sugar content that's slightly higher than what I would fit in with the US guidance on sugar consumption by toddlers. So definitely a ladder to look at as well, if that is your preference. And then of course you have the Canadian milk ladder with, more foods that's commonly eaten in Canada. Once again, free to download. And then I will just summarize. So we have 15 minutes for questions and answers. Milk is one of the most common and complex presentations of food allergy in early childhood. Non-IgE mediated allergies such as proctocolitis most often present in infancy. It typically resolves by 1 year of age. IgE mediated cow's milk allergy can also present in infancy and resolves in about 80% of children. Regardless of type of cow's milk allergy, it's managed through dietary avoidance and an individual avoidance approach, and making sure that nutrition is sufficient. Baked milk can be introduced on recommendation of your allergist. And remember that ladders were designed for non-IgE mediated cow's milk allergy in the context of today's talk. So they're not meant for FPIES and EOE, unless that is what your allergist suggests. And it should only be used for IgE-mediated allergy under the guidance of an allergist. So thank you very much for your time. And both Marion and I look forward to the Q&A session.
Terrific. So Marion and Karina, I'd ask you to turn on your webcams so we have the opportunity to see you. Thank you very much for that presentation, and your timing is perfect to allow us sufficient time to get through some of those questions, so well done. So the first group of questions that were submitted were really around this idea that people could have an allergy or sensitivity to only milk or ice cream or some products, but then not other milk products like yogurts or cheese. Or combined with that was, someone who is allergic to cow and goat's milk, but not sheep's cheese, right? So can you talk to us about this possibility and what might explain why people can tolerate some forms of dairy but not others?
Yes, Marion, if you don't mind, I'll go ahead with that one. We understand so little about how processing and heating affects cow's milk allergenicity. And for example, as part of the DRACMA series of papers, I've recently been involved in a paper on processing. And certain types of milk processing actually increases the allergenicity of milk, whereas we know when we bake it, we reduce the allergenicity. As I'm saying that, please have a look at particularly the Mediterranean milk ladder. There's two proteins in milk, main proteins, the casein and the whey. And we used to think that casein is not affected by baking or heating, but that the whey sort of like gets completely unraveled or denatured, and that it's still there, but the immune system can't recognize it. But when we actually did the analysis for the Mediterranean milk ladder, none of the proteins actually reacted or acted to heating as we thought they would. And so I think the short and the long is, first of all, our immune systems recognize different proteins and different fractions of proteins to launch an allergic reaction. How heating affects these different proteins and fractions, and we're still learning. And for example, I've never seen anybody who only reacts to the kappa 1 casein to milk. But if your immune system only pick that one, then you can eat cheese without a problem, because there's no kappa 1 casein in cheese. So to cut a long story short, I think it's possible. Clinically speaking, we're always going to give avoidance advice on no cow's milk protein, stay away from other mammalian milks, because we know cross-reactivity is very high. But look, if you're milk allergic, you're adamant that you want to give your child goat's milk, and your allergist is happy to bring you in for a food challenge and you're willing to come in, I guess it's worth doing and see if the child tolerates it. It's going to happen in about 10% of cow's milk allergic cases. The majority won't tolerate it. And Marion, I don't know if you want to add to that, but
No,
I hope I've
I think you've
addressed it.
answered it really well. I mean, you know, typically we see a co-reactivity between, or cross-reactivity between cow's milk and goat's milk and sheep milk. But like you said, about 92% of people with cow's milk allergy will react to these other goat's milk. That means that there are 8% that are going to be fine with it. And the reverse has happened. I mean, I have seen in our clinic somebody who reacted to sheep's cheese, but has cow's milk all the time and does fine. So like I said earlier, in food allergy, we never say never and we never say always.
Awesome. Okay, great. So related, but maybe you can get into a little bit more detail around the concept of the milk proteins. And I recognize you just said, well, we haven't figured all of this out, but this is the different forms of dairy, from raw, baked, butter to ghee, right? Like, can you walk us through how the milk proteins are different in those type of formats?
I'll start with butter and ghee because that's going to haunt me forever, because everybody wants butter and ghee in the ladder and wants to know why I am so stubborn not to allow it. And so with the Indian ladder, we actually did say if you want to start with ghee as the very first step, you're very welcome to. My issue with the butter and the ghee is it's not well heated, but the majority of butters and ghees may have zero milk in it. Then when we called the companies in the United Kingdom where they were willing to give us information on the milk protein content in butter, some of the butters actually contained more milk protein than 2 or 3 cookies, and it wasn't really well cooked, as we know that butter is raw. And people say, but why don't you just put butter in something and cook it? Well, that puts another complexity to it. So my short and long about butter and ghee is many children may tolerate butter and ghee even before the first step of the ladder, but it depends which one you pick, and we don't have that allergenic protein content for all the butters and ghee. And as Mary know, I often joke and say Marion and I have a food allergen black market between the two of us, because we share information that we get from companies, because it's very hard to get this information. So I think I answered butter and ghee, and I forgot the rest of your question.
Well, they're raw and baked, right? So, and I think you talked about, I mean, certainly the raw is at the top of the ladder. So I think you've kind of addressed that throughout. So,
Okay.
okay. So there are a couple of questions around clarification that have come in on terminology around diagnosis. So, and I'll give you both of the questions that have come in. So one is, is FPIES cow's milk allergy considered IgE mediated and non-IgE mediated? And then the other part of that is, on the question of diagnosis, can you kind of go back and restate how an allergist would determine whether it's an IgE or a non-IgE mediated allergy? Like, what's the testing that they're doing? So if you can, because I think we've introduced the labeling of IgE and non-IgE. So I think spending a little bit of time kind of revisiting those two topics and how they're diagnosed would be helpful.
So I'll go ahead and start with FPIES. So FPIES is a non-IgE mediated allergy. When we talked about food protein induced allergic procticulitis, or cow's milk protein allergy, we talked about it being sort of a mild type of non-IgE mediated allergy. But FPIES is not necessarily mild. So even though children with FPIES are not at risk of anaphylaxis, the reactions that they have can be quite severe, and they can be a medical emergency. So the reaction with FPIES is, an acute form of FPIES would be the onset of vomiting, usually between 1 and 4 hours after they eat the food. And it's a repetitive, forceful vomiting. Some of these children, about 10 or 20% of these children go on to have hypotension and hypovolemic shock. So some of these children need to go to the emergency room and be treated with IV fluids. So it's a stressful type of food allergy. I think parents really struggle with feeding because they're so afraid of triggering this type of reaction. And I'll sort of segue into the diagnosis and then I'll hand it over to Karina. The reason why it's so stressful is that with non-IgE mediated allergies like FPIES and like cow's milk protein allergies, we can't test to determine what foods are triggering the reaction because all of our tests are actually looking at the body's immunoglobulin E, IgE. And because these are non-IgE, we don't have any good tests to tell us what foods can trigger that reaction.
Yeah, I think Marian explained that well. So I think there's 2 steps in diagnosing, well, perhaps 3 steps, but the first 2 are the most important in terms of diagnosing IgE-mediated food allergy. The first step is the questioning. So when did the symptoms occur? Normally within 2 hours. As Marian have said a few times, there's always outliers, but we would normally expect symptoms of an IgE or immediate type food allergy to occur within 2 hours.
And
as
usually
much as,
pretty soon after the food is
yeah,
eaten.
I want to say, normally, even though we give ourselves the 2-hour time limit, it's going to happen soon. Like literally seconds, minutes, we don't normally sit and stare at children for 2 hours in a food challenge before they react. And we normally wait 15 minutes or to 20 minutes between steps in a food challenge, and they will normally react within that 15 minutes at least. So, and the symptoms, as I've said, but I will just highlight again, Marian, you can add, it's hives, so urticaria, it's swelling of the lips and eyes, it's babies turning bright red, babies getting itchy, they get this feeling of doom, so babies may just all of a sudden go in, like a playing possum position or just become just very sleepy. Often what I see with babies and young children is they grab the tongue because they start getting this itching feeling in their mouth. For me, that's normally the first sign of a baby is going to react. If they grab their tongue, you can start looking for hives and swelling. And like I said, often they get also the rashes around the mouth. And so I think that is the majority, and the wheezing. They can start wheezing as well. So that's the first thing. You now know you've got symptoms that sound like they've got an immediate type food allergy, and the symptoms occur really within 2 hours. The next step is to say, okay, I need to find out if I can support this with IgE production. So the IgE production we can measure 2 ways: either a skin prick test, which you put a drop of allergen on the skin and prick it, and a wheal will form, or you can do a blood test to test for circulating IgEs in the blood. And then normally that will be positive. I don't really want to go on to cutoff points and positives because particularly in babies, I think, the positive really need to be interpreted by the allergist. But normally if you can detect IgE in a baby or you have some sort of a positive wheal on the skin, that support the history of immediate type symptoms. And like I said, if there's anything that's still unclear, you can then bring the baby in for an oral food challenge where we feed them milk in graded dosages. But 99% of the time, if you have a clear history of symptoms and you have a positive skin prick test or specific IgE test, we wouldn't necessarily put families through the hoops of coming in for a food challenge, which we know that's going to be positive. I hope that explained it well.
Well, thank you. That was great. So a couple of questions on alternative diets. There's a few questions that came in with regards to soy, okay? And that considering soy products as a replacement for dairy, people are asking, should they be worried about phytoestrogens or GMO? Can either one of you address that question?
I'm happy to take that. So, I understand people's concern about soy. There's a lot in the popular press about negative consequences of these phytoestrogens in soy. It's not really supported by the literature. So in infancy, we do say we don't usually recommend soy before 6 months of age, mostly because of these weak phytoestrogens, and that is the sole source of food in an infant's diet. But once you get to a year of age and a child is getting, 2 cups of soy milk per day and eating a varied solid food diet, there are probably more health benefits than harms to having that amount of soy product. I wouldn't be taking like isoflavone supplements or things like that, but certainly soy in its natural form, or in like tofu or in a soy milk or edamame, would be perfectly safe and healthy.
Great. Okay, we're getting close to wrapping up. We're going to go just a couple of minutes over, but I want to finish with this final question because there's a few that people who've raised it. It's around this, when do you consider an oral food challenge, right? So you gave us the statistics around the possibility of outgrowing milk allergy, but when does someone kind of press in to say, okay, let's go and get an oral food challenge? Who'd like to tackle that?
I'll start with that, and I'll just say, one of the most important reasons why you continue to follow up with your allergist is that the allergist is going to be looking for signs that you might be outgrowing your allergy. So for IgE-mediated allergies, they're looking at that serum-specific, that food-specific IgE in the blood. They're looking at your reaction history. So say you haven't had a reaction in a number of years, and those IgE levels are coming down, and they're sort of now in a point where the doctor says, gee, you may have a 50-50 chance of passing an oral food challenge. They may offer that to you. So this is why, some people say, well, I'm allergic, so I don't go to the doctor anymore. I know how to avoid my food. But it's really important to continue to follow with the doctor, because the allergist is going to tell you when you may be ready for an oral food challenge. And just because the levels are going, just to sort of reassure people, they have a young child and the levels seem to be going up every year, that doesn't mean that they're not going to outgrow it. It just means that they're not outgrowing it right then. So just keep following up, and hopefully you'll have a good result.
Yeah,
Great.
I'll
Karina,
just quickly add to that. For my PhD, I had a prevalence study, and for research, I had to do those challenges to prove that they're allergic. But we knew they were going to react, and they did react every single time. So for clinical purposes, there's no point doing these challenges. And like Marian said, in the majority of cases, we do challenges to see if children have outgrown their allergy. But in terms of baked milk, I would say one change in our clinical practice recently is we used to diagnose them with milk allergy, based on history and skin prick test specific IgE, then wait 6 months or a year even to do the baked milk challenge. But now we will bring them in straight away. So in that sense, I guess we're doing a diagnostic baked milk challenge because we want to diagnose if they baked milk tolerant or not, which we can't tell from the history. So that's one case where history and specific IgE is not going to give you your answer. You're going to have to bring them in, challenge them, and see what happens. So that's sort of like at the starting point of diagnosis. But for the rest of it, like Marian said, it's really to determine tolerance development.
okay, terrific. Well, thank you very much, Karina and Marian. That's been a great session. I'm going to ask you to turn off your webcams, but we just want you to know that we really appreciate you sharing your time and expertise with us today. So I'm going to go through just a couple. I'm just going to go through a couple of slides here on some of the things that are coming up next. So following this session, you'll get a survey that asks for your thoughts about the webinar. Please do take a moment to fill it out. It really helps us improve our programming and provides us with insights on other topics you would like us to cover. For more on CMPA, watch our recorded webinar, Cow's Milk Protein Allergy in Babies, what it is and how it's managed, at foodallergycanada.ca/webinars. Today's session also highlighted the importance of reading the label, both the contains and the may contain statements, and knowing what's in your food. To learn all about label reading or refresh your memory on that, including the triple check, see that at foodallergycanada.ca/labels. Back to school is now underway, and if you haven't already taken advantage of our host of resources we have on our site, please do go to foodallergycanada.ca/back-to-school. There you're going to find some videos, handouts, and more. And please do get involved in our More Than Peanut social campaign, which is about creating awareness for all allergens to help prevent reactions. The posts are insightful and very shareable. All you need to do is share the posts to help broaden the reach of the campaign. Now, a few things on September. We've got our next webinar is Thursday, September 28th. This is covering the importance of using epinephrine to treat anaphylaxis, and it really gets into the safety concerns and the questions that you have posed to us in the past around first generation antihistamines like Benadryl. So that's one that you can register for now by going to our events page. We also have the fall session of our Allergy Pals and Allies online mentoring program. It starts on September 24th. This is a program that connects kids with food allergies ages 7 to 15 from across Canada, and the feedback we get is that it's been life-changing for those participants. In terms of upcoming webinars, you've heard throughout the presentation that we have some specific webinars on some of the non-IgE mediated food allergy. On October 11th, we will be covering eosinophilic esophagitis in adults with Dr. Millie Gupta. Pardon me. And on September 27th, we have a session on food protein-induced enterocolitis syndrome, or commonly referred to as FPIES. That features Dr. Anna Novak. And on December 12th, we'll be covering a topic of immunotherapy in food allergy and desensitization with Dr. Philippe Bégin. For more information and to register, you can see that at the foodallergycanada.ca/events page. We would like to thank the following back to school campaign sponsors for this event: Allergic, Peanut Bureau of Canada, Chapman's Ice Cream, and EpiPen. Thank you for your participation in today's webinar. You can review a recording of the webinar at foodallergycanada.ca shortly. Please also share with others who you think may benefit from this content. This now concludes our webinar.